All right, we're going to start off just hoping to understand gravity and parity. Now, gravita is a term for the times a woman has been pregnant. So her total number of pregnancies, including the pregnancy she is currently having if you're caring for a pregnant mother. Nulla gravita means she's never been pregnant. Prima gravita means this is her first pregnancy. Multigravida is a woman who has had 2 or more pregnancies. Parity is the number of pregnancies in which the fetus or fetuses have reached viability. So whether the fetus is born alive or stillborn, if it makes it to 20 weeks, it is considered a para. Nullipara is a woman who has not had a pregnancy that has reached 20 weeks. Primipara is a woman who has completed a pregnancy with a fetus that has made it to 20 weeks, and a multipara has completed 2 or more pregnancies past 20 weeks. Now, viability in your book says, okay, at about 22 to 24 weeks since the last menstrual period, the fetus should be able to live outside the uterus. And you're like, well, didn't you just say 20 weeks was viability? But think about it this way. The pregnancy doesn't begin right after the last period, okay? You have about 2 weeks before you ovulate and then conceive and then implant and be pregnant. So the viability is 22 to 24 weeks after the last menstrual period. Para, which is a standard for viability, is 20 weeks. Now, a preterm gestation is a pregnancy that has made it to 20 weeks, but it is delivered before a completed 37 weeks gestation. So anything from 20 up to 36 weeks and 6 days is considered preterm. Your term pregnancy is anything from the beginning of 38 weeks to the end of 42 weeks. I'm old school. I think from 37 and 0 to 42 weeks is term. There are some schools in your book that says it has to be 38 and 0 before you have a term pregnancy. Now, post-dates post-term, and really it's post-mature, is your pregnancy that goes beyond 32 weeks of gestation. And I will tell you, I don't know that I have ever seen that. Most providers are not going to let a pregnancy go beyond 42 weeks. So how do women find out if they're pregnant? Well, there's a lot of pregnancy tests available, but HCG, human chorionic gonadotropin, is the earliest biochemical marker of pregnancy. So that really is what we test for to see if we're pregnant. You can have the beta subunit, so beta HCG, that begins production as early as the day that fertilized egg implants. And it can be detected with tests as early as 7 to 10 days after fertilization occurs. As I said, there are many different pregnancy tests available. The one that is more commonly looked at and utilized is the ELISA. This is the most popular method for testing pregnancy. It is an over-the-counter home pregnancy test. Pretty much the biggest reason women have inaccurate results from their home pregnancy test is that they do the test too early. They don't give the HCG time enough to be produced and to be detected. So they'll say, whew, I'm not pregnant, but they actually just didn't give it time. I typically will tell a woman not to do a pregnancy test until at least 7 days after she thinks she could have gotten pregnant. So say she had sex today and something happened, a condom accident, or just didn't use something, or forgot her pills, whatever. If she wanted to do a pregnancy test to see if she could have gotten pregnant today, she would need to wait at least 7 days before doing a pregnancy test. Now, we do have a pregnancy test to tell us are we pregnant or not. However, Women will rely on symptoms and things they see in old wives' tales as much as anything else to say, oh my goodness, I think I'm pregnant. Maybe I need to do a pregnancy test. So when we're thinking about signs of pregnancy, we have three categories. The presumptive signs are specific changes that are felt by the woman. Maybe she has some nausea. Maybe her breasts feel fuller and more tender. Okay. Probable signs are changes that are observed by the examiner, and it can be changes in the uterus, the size, the color of the cervix, the softening of the cervical isthmus. The positive signs of pregnancy are those signs that are only valid in the presence of a fetus, like you have a fetal heart rate, cardiac activity identified on ultrasound. You see a fetus in the uterus on ultrasound. In thinking about what a woman's body goes through as it adapts to pregnancy, we'll start with the reproductive system first. Now, the uterus is obviously going to change size, shape, and position depending on where it is in the pregnancy. It's going to be 6-7 weeks in the pregnancy before the uterus starts to expand. When it does start to expand and that fetus starts to grow, a woman is going to feel probably something very much like menstrual cramps. And there are many women, myself included, who said, oh no, I can't be pregnant because I'm having cramps. I know my period's coming on. That's actually the uterus growing and stretching. Braxton Hicks contractions aren't going to occur until later on in the pregnancy, but the changes in the contractility of the uterus will have these spontaneous contractions developing. We do have the very specific circulation of the uteroplacental blood flow. We talked about that in Chapter 5 with our embryologic development. Remember those signs that I said the provider can see earlier, just in the previous slide? Well, our cervical changes that we look at, the Hagar sign is that softening of the isthmus. So kind of like that cervical tunnel, it's going to be a little bit softer with palpation. Goodell's sign is when the cervix itself softens. So instead of being a firm, almost rubbery-like texture, it's going to be softer. And then Chadwick's sign is when the cervix takes on a bluish color and a bluish tinge. Now understand, just because those signs have names and they're present doesn't always mean that they're going to be immediately and easily distinguished by the provider. And then changes in the reproductive system that are related to the presence of the fetus. Ballottement is when the fetus is in there and you can actually, through the vagina, the provider can take their fingers and kind of bounce the cervix and kind of tap against it, and the fetus will ballot in the amniotic fluid. Quickening, like we talked about earlier, is that perceived fetal movement that occurs somewhere between 16 and 20 weeks. Vaginal discharge is going to change, and one of the changes is an increase. The discharge itself becomes creamier, whiter, and more copious, which, if you look at the term leukorrhea, that's the excess white discharge. The pH also becomes a little bit more acidic, and therefore it provides some protection against infection, but it is not a complete protection. A woman's breast will begin to feel heavy and full, and they may be very uncomfortable. Even wearing a bra could hurt them. The nipples become very sensitive, and they can tingle. They can have sharp pains from just a bra rubbing against them. The areola become darker, more pigmented, and then you have the development, kind of the increased expression of your Montgomery's tubercles. And colostrum can actually start developing as early as 16 weeks. So you may have a pregnant woman come in and say, my breasts are leaking, what's going on? Well, depending on where she is in her gestation, it may very well be colostrum development. We all know women breathe differently when they're pregnant. There is just a shift of everything. They tend to breathe shorter, more rapid breaths. Their diaphragm, especially later in the pregnancy, as the pregnancy advances, can't drop down because the fetus is in the way, and so they are feeling short of breath all the time because they can't fully expand their lungs. The renal pelvis and their kidneys and the ureters dilate about 10 weeks in. And so, because of this, if they go into especially a left lateral sideline position, you can have increased perfusion through the kidneys and it can increase the urinary output. Selective renal tubular resorption maintains the balance between your sodium and your water intake. The cardiovascular system in pregnancy is one of the cool systems, and as far as the adaptations and what it does to help a woman maintain her pregnancy. Because blood pressure is so very important, and it is one of those indicators that can say if a pregnancy is about to have trouble or not, it's very important to monitor blood pressures accurately, use good technique, appropriate size cuff, but also to understand what your reading should be. Your systolic blood pressure for your pregnant woman should remain consistent to whatever she was pre-pregnant. So if her systolic pressure was 110 to 120 before she got pregnant, it should be that in pregnancy. We do not want a systolic pressure above 140. The diastolic pressure decreases up into the third trimester, and then it returns to the pre-pregnancy rate. We do not want a diastolic pressure above 90. So for a pregnant woman, ideally blood pressure is going to be less than 140 over less than 90. Anything above that is going to indicate health problems. For blood volume, it increases, and the composition, what makes up the blood, is going to change a little bit. There is going to be about 1,500 milliliters of fluid extra for the woman. The body is miraculous. It knows it's going to bleed, okay? It knows it's going to have extra fluid needs carrying for the mother and for the fetus, so it's going to increase its circulatory volume by about 1,500 mLs. That equals about 40 to 45%. 1,000 mLs will be plasma, and about 450 mLs is going to be red cells. In pregnancy, a woman will have something called physiologic anemia, where her hemoglobin is somewhere between 11 and 12. Now, for you or I, a hemoglobin of 11 or 12 is going to be anemic. It's anemia in pregnancy, but it's more of a dilutional anemia. She has all this extra fluid, so her hemoglobin looks less, when actually it's not. So that's why we will allow pregnant women to have a little bit lower hemoglobin levels. Now, iron deficiency anemia is when the hemoglobin is less than 11 in pregnancy. So we'll give her 11 to 12 and just make sure she's having a good diet and watch it. But if it falls below 11, we're going to intervene and do something about it. Obviously, because of the volume, she is going to have an increase with her cardiac output, and there's going to be some concerns with circulation and her coag times. In the GI system, a woman's appetite is going to be varied depending on where she is in pregnancy. In the first trimester, she's probably not going to have much of an appetite, especially if she has the quote-unquote morning sickness, which is sickness that doesn't just occur in the morning, it can occur anytime. Her mouth may be uncomfortable because she may experience bleeding gums, and when she brushes her teeth, she may notice the bleeding, so her mouth may become sensitive. It is very, very important that during pregnancy a woman maintain good dental hygiene and has her Teeth checked by a dentist every 6 months at least. As the pregnancy advances, everything in her abdomen, so her esophagus, her stomach, the intestines, everything gets shifted as the pregnancy advances and the uterus expands. The muscles, the tissues, everything's going to slow down. So instead of food passing through the digestive tract and digestion occurring, it kind of becomes stagnant. Digestion slows, and women are more prone to heartburn and having issues there. You hear of women having to have their gallbladder removed in pregnancy. That is not an uncommon finding. Diastasis recti is when the burgeoning uterus actually puts so much force on the abdominal wall that the rectus muscles that go longitudinally up and down the abdomen separate. They stretch, and you can have herniation, and we call that a diastasis recti. Changes in the skin that you need to be able to talk to your pregnant patient about is chloasma or melasma, which is the mask of pregnancy. She will actually get darkening, hyperpigmentation of the skin, kind of around the eyes, down the center of the face, over the nose, and around the mouth. This should resolve after she has the baby. An interesting note, women who take birth control pills, because the birth control pills mimic the hormones in pregnancy, will often experience a development of a chloasma as well. The linea nigra is the dark line that goes from just under the breastbone, and it kind of bisects down over the abdomen, goes over the navel, and down to the symphysis pubis. That line darkens, kind of the same way the areola become hyperpigmented and darken. You'll have that line going down the abdomen. It typically lightens up after the pregnancy is over. Striae gravidarum is a fancy word for stretch marks. Now, stretch marks are hereditary. If your mom had them, there's a good chance you had them, okay? I really am still out on the decision of whether the massaging, the cocoa butter, and all the oils and everything make a difference. I know taking good care of your skin, keeping your skin supple and moist and elastic can help with the stretch marks. The good thing is they won't be highly visible forever. Now, once they're there because it actually tears the elastin in the skin. However, they fade out, and instead of being that bright red, angry color, they become kind of silvery stripe over years' time. The musculoskeletal system, posture is going to be very awkward as the belly continues to grow because the center of gravity gets off put. So she's going to become a little bit sway-backed, and you'll see that typical waddle gait of a side to side because the pelvis just can't rotate and move and glide easily with the heavy weight of the fetus in the pelvic girdle. And taking a really quick look at our endocrine system, remember we talked about ovulation and menstruation and estrogen and progesterone kind of triggering everything? Well, in pregnancy, estrogen and progesterone inhibit follicle stimulating hormone and luteinizing hormone. I mean, why do we need to stimulate a follicle for ovulation? We're already pregnant, right? And you don't need the luteinizing hormone, you don't need the corpus luteum for the progesterone because the placenta is taking care of that. The progesterone from the placenta is necessary for maintaining the pregnancy. The progesterone relaxes the smooth muscle, so you're less likely to have an irritable uterus and contractions. Now, sadly, the progesterone doesn't just focus in the uterus and the smooth muscle there. Remember our digestive system and how everything slows down. Women are more at risk for constipation, digestive disorders. Thank your friend progesterone. And then we have oxytocin, which is that love hormone that makes us all warm and cuddly whenever we're holding our baby. And it's also going to be that stimulant hormone that is going to help with our uterine activity in labor to create the contractions that's going to expel the fetus from the uterus. And then after we've had the baby, it is going to help with when we're breastfeeding to tighten up that uterus to help minimize any bleeding and hemorrhage potential. There is some degree of thyroid enlargement that a provider may see. So all thyroid glands are assessed, but it is not the easiest thing to just really, it's not such a large enlargement and not so obvious that you'll be able to just look at them and say, oh my goodness. There may be a slight increase in parathyroid gland activity, so there may be a little hyperparathyroidism, so you'll need to watch the calcium levels. The pancreas does decrease the production of insulin early on in the pregnancy, but as the pregnancy advances, in response to cortisol, you're going to have increased insulin production. So we've talked about a lot of different systems and changes that the female body goes through when pregnant. So let's just take a look and see if we can identify what's going on here. So if you look over on the left side and look at A, you can see, kind of firm, uplifted breast, relatively, flat abdomen, not a heavy mons or anything in the upper graphic. And then in the lower graphic, when you're looking at the cervix, take a look at the head-on part of the cervix. The os, the opening is just a little round circle. Well, when you look over to the B side of the slide, the breasts are heavier. There's been some changes in that. You can see the fullness in the abdomen, the darkening of the linea nigra, and kind of that little fold there in the groin area, the symphysis pubis, is a little more plump. And then if you look down at the cervix, you now have a little smiley face, a little slit where that cervical os is. So even if a woman tells you that she has never had a baby, if she has an os that looks like B, she's had a baby. If she has one that looks like A, she hasn't had a baby. Here we can see how as the fetus grows and the uterus grows, it correlates in centimeter markings to gestational age. Now we call these fundal height measurements. So the very top of the uterus is the fundus, and we measure from the symphysis pubis to the top of the fundus. We measure that in centimeters, and whatever centimeters we get in measurement, that should reflect how many weeks pregnant the woman is. So you can see 12 weeks gestation is actually still pretty low, and you may or may not even be able to feel the uterus over the pelvic brim. 16 weeks gestation is about halfway between the belly button and the symphysis pubis. And then 24 weeks to 28 weeks, 32 weeks, all the way up to 36 weeks. At 36 weeks, we're going to be just about under where the xiphoid process is. Then, as the pregnancy goes, you notice at 40 weeks, we actually drop down. And that's because the fetus is now engaging and dropping down into the pelvic cavity. So you actually lose a little bit of the fetus back down lower. So 40 weeks is actually going to mark at a lower point than 36 weeks did. So here you can really clearly see how the advancing pregnancy and the growth of the fetus really impacts where internal structures lie on the mom and just how the mom's body has to change to accommodate the growing fetus. So at 4 months, it's still kind of small, all right? You notice she just has that little bit of tummy bulge, but the upper abdomen is still relatively flat. The fetus is just floating around in there. It's kind of lifted up off the bladder a little bit, so she may not be going to void as much. And the intestines, everything is still pretty much where it's supposed to be. But progress forward to 6 months in the pregnancy, And now she's starting to get that little pull. The belly is pulling forward, so she's going to get a little bit more sway back. You can see that we're starting to shift upward. The liver, the stomach, the intestines, things are becoming displaced now. So you may have your mom who is not eating as much because she doesn't have the same stomach room because of the growing fetus that she had when the fetus was still low. And then by 9 months in pregnancy, the fetus is head down, very protrusive in the abdomen. You've just really displaced everything in the abdominal cavity because the fetus and the uterus is taking up all the space. And this slide is just showing you what I was talking about earlier when we were mentioning ballottement. So if the provider were to take his finger or her finger and just flick against the cervix, then because the fetus isn't so large that it is taking up every bit of space in the intrauterine cavity, it's floating around in the amniotic fluid, that fetus will actually bounce up and down, float up and down. That means it's not engaged, it hasn't locked in, and it is still free floating. All I can say is, thanks, Mom. This poor woman is someone who does have a lot of the stria gravidarum, stretch marks by any other word. On her, they are dark, hyperpigmented, and I've actually had women say that they itch or they hurt whenever they were this bad. The good thing is they will fade out. They will never go away. The only way to have them gone is to surgically remove them. But they will fade out to a pale silvery color over the next 12 months or so. And here you just see the postural changes. The shoulders kind of lordosing a little bit, bringing forward, or you got kyphosis and the lordosis of the spinal curvature as the fetus is enlarging in the uterus. And this offsets her center of gravity, so she is more ungainly in her walk. She gets that waddle walk, and she's actually more at risk for falling because she doesn't have that stable center of gravity. All right, remember that herniation of the abdominal support muscles I was telling you about, the rectus abdominis muscles? Well, normally, if you look at side A, they are just nice, strong, linear abdominal muscles which are responsible for holding our bellies in and holding us upright. And they're just joined by connective tissue. Well, as in side B, once you've got a baby in there, especially if it's a large baby, if you're a short woman, didn't have anywhere for it to go but out, then you're going to have so much constant pressure against those abdominal wall muscles that it can actually tear that connective tissue, and you can have separation of those rectus abdominis muscles. The technical term for this is diastasis recti. Years and years ago, there was actually a practice where women would go to plastic surgeons and say, I would like to have a tummy tuck done, but I don't want to have to pay for it. And so they could look and they could see just how much of the rectus muscles had separated, how many babies had they had, when did they have their babies, and they could code it that it was a diastasis recti hernia, and the repair was necessary because it was a herniation and the woman didn't have to pay for it. I don't think they do that anymore. And we've talked about just how pregnancy changes the body and things shift, but depending on where we are in the pregnancy and how advanced it is, pregnancy can make it difficult to diagnose certain conditions. One very classic one is appendicitis. You don't really think about pregnant women having appendicitis, but what's the first thing that you always want to check when you're worried about that? You want to see, do they have rebound tenderness, right? So you want to go to McBurney's point, do the in and out palpation to see if they scream and is there guarding whenever you do that. Well, look on the diagram here and see where McBurney's point is and the position of the appendix in the non-pregnant person. Okay, where you want to be, right lower quadrant. as the pregnancy advances, remember we just displace all of the internal abdominal content. So the belly moves, the small intestine, large intestine, everything gets shifted. So look at as the pregnancy advances, 3 months, 4 months, 5 months, so on, where the position of the appendix is. By 8 months, it's almost up at the costovertebral angle, so about where the kidneys are, not down in the right lower quadrant. So it's actually above the belly button once you start hitting 8 months. So you can see that pregnancy has the potential to mask so many other disorders, and we're so worried about a pregnancy anomaly, we may miss a non-pregnancy situation. Well, alrighty then. That's all I have for this lecture. We will talk about it in class on Monday. And please write down any questions you have so that can kind of guide us on what we need to review. I hope you've enjoyed listening to this as much as I've enjoyed recording it for you. And I will see y'all in class. Have a good day.